Welcome to The Inside Track, where we talk all things health, healthcare and medical insurance. Brought to you by TRA and our team of Warren, Alan and Doc Avron. Let's sit back and see what our team has for us today.
Hi everyone, and welcome to podcast number 7 in our Inside Track series. So it's hard to believe that we're already at episode 7. It's so exciting. Today we listened to part 2 in our medicinal cannabis series. And based on the reaction we had to part 1, we know that there's viewers glued to their screens right now as we release this episode. And we can't wait to hear what Doc Anton had to say in that second episode. Doc Avron, what does he focus on in part 2?
Yeah, just to tell listeners or someone maybe who's just linking in onto and they didn't hear part 1, but Dr. Anton Janssen van Rensburg is an expert in this field. He does train other doctors, and there are not many in South Africa in terms of medicinal cannabis. And really, this episode was actually going a bit deeper, looking at the exact indications. How do you dose medicinal cannabis? What are the side effects? And also, what are the costs? So I think there's a lot of information here, and I'm sure our listeners will find it fascinating.
Great. Let's have a look.
Great.
So now I think we're going to go into the area which you brought up a bit earlier in terms of the risks and limitations, right? And we're talking about getting hooked or addicted, etc. And let's start sort of saying, what are the main side effects that a patient should be aware of when starting this type of treatment?
The main side effects are absent if a patient does microdosing. I think one of my biggest problems is people, want to know, should I feel anything? Because I've already been taking it for a week and I don't feel anything, from a side effect, because they're waiting for the side effects. They say, will I be high? If you get high on medicinal cannabis, then carefully go and read your prescription again.
Yes.
Carefully go and have a look. I had one patient who confused the word drop with milliliter. So instead of 1 drop, he was taking 1 milliliter. Now that's 20 drops, and to start on 20 drops is going to affect you. So that is there. It's like taking too many of your sleeping tablets in one night. You get the dose wrong. So, the people that I work with at IntroCan have a nurse on standby to guide the patients. And I found that probably with cannabis as medicines, one of the most important things that I've seen is that there are people like a nurse that's available on the phone to guide patients. But from a side effect perspective, that's the big issues. Just not overdose, because obviously you can experience that little bit of a feeling of feeling high.
Yes.
Few people get there. Some people just wake up the next morning after taking too much, and they've maybe got a slightly reddening of their eyes. They may feel a bit drowsy. That's as much as I have seen with my patients so far. But because we're dosing so low, I don't see many side effects.
So you shouldn't be getting high, right? In general, we're saying.
No.
And talk to me a bit about addiction, right? Because this is definitely a question mark that's coming up. And I'm sure our listeners are thinking about, and I know you said earlier in the show you would expand on this, but are there, even on microdosing levels, which we're talking about here, are there risks of addiction? And what's the data saying on that?
Yeah. So there's quite a few studies that were done about the addictiveness of cannabinoids. Now, firstly, cannabis is a little bit addictive. We have to agree on that. But so is caffeine. So for all the coffee drinkers out there like myself, cannabis is slightly less addictive than caffeine. So you still have to be careful with it. It's like even with your coffee consumption, don't drink 15 cups of coffee a day. Maybe you should cut back a little bit. It's not good for you. But when we look at, when I go back to the whole concept of the exit drug, how I exit people off pharmaceuticals. So I've got a list of pharmaceuticals that I've, in my 27 years of practice, seen that are way more addictive than something like cannabis. And that includes smoking, just smoking a cigarette. Few people realize that actually smoking is one of the most addictive things you can do. It's on the level of cocaine to smoke. Alcohol is much more addictive than cannabis. Opioids, benzodiazepines, non-benzodiazepine sedatives, long list of medications. And Professor Nutt in the UK has actually done quite a bit of research to place, where do you place cannabis in this whole continuum? So it's on the continuum. So I always tell my patients, just remember now, I mean, it's like I'm now prescribing you something that would be like a benzodiazepine or something else, but at least not that addictive. So we're going to keep it low and we're going to go slow.
In other words, what I mean by, let's say you treating someone with microdosing of cannabis and tomorrow I stop, right? I say, am I going to get withdrawal? Say your typical withdrawal of addictive drugs.
No, you're not going to get withdrawal. The only person in my 6 years of prescribing cannabis so far, I had one patient who had withdrawal. He was smoking 8 joints a day. And that was my first encounter with proper withdrawal. But his withdrawals were not the type of withdrawal you see in the movies where people have to lie in a room and they're sweating and they're shivering. He was just being irritated with his staff at his workplace, and he was irritated with his wife, and he was a bit jittery and he was a bit anxious, and it passed in about a week. But I've never seen in my world of microdose medicinal cannabis, I've never seen a withdrawal when a person just stops it.
Fine. So in summary, if it's being given correctly, you should not be becoming addictive. Well, in terms of what we would traditionally think is addictive to cannabis. And secondly, there shouldn't be withdrawal symptoms if we stop it.
That's right.
Right. So if we have a patient who's considering medicinal cannabis, right, out there and saying, okay, well, maybe what I have on my disease states fits into these categories, what steps should they take?
I usually refer the patients to Intracan. Intracan is a administrative platform, intracan.com. They then are taken into a system where their administration is supported and where they have access to this nurse practitioner or the nurse coach. I have to mention the nurse again because I've seen over the years now many people need support to know how to titrate. And they then can register there as a patient and they can be linked. There's a handful of doctors in the country that are now trained in the field and they will be linked with a doctor. Or they can just go to their doctors and ask them, don't you want to get educated in the field? And that doctor can do my CPD course and become educated in the field. I wish more doctors would do that.
Right. And how many doctors are there like you who've been trained in South Africa to actually prescribe cannabis?
I think more than 200 have been trained, and I think actively prescribing maybe 50 or 60. A little bit of guesswork there now because there are few organizations that do this, but not too many are prescribing, and I'm really hoping that more will start.
Okay, so it is a growing field, that's what you're saying, and we're going to see it grow in South Africa. But what you are saying is that you need to go through the right channels, right? You told us the website. What's that website?
It's Intracan with 2 N's at the end.
Right. We'll put that on this podcast. And through there would be a list of registered practitioners, I presume. Is that correct?
Yeah, when you register there, you can reach out to the people there and ask them, where, in what region are you? Can you be linked to a person that actually does do it? But also virtual consultations makes it that your region doesn't really matter. They can link you to a person that's willing to do a virtual consultation.
Right. And now so you told me, do the research, go to the website, get a registered doctor. So you go, or ask your GP in terms of, or your physician, how do you get there? I presume, hopefully. I suppose the big flag should be even doctors who may think, obviously, registered accordingly, they may not be trained in this area, and then you wouldn't want them to obviously prescribe to you. You'd want someone who's an expert in this area. Am I correct?
Yeah, they would have to go through the training. This is a separate training that a doctor needs to undergo.
Fine. And then let's go to the medical funds, right? I want to go to a doctor. I want to get, it's obviously appropriate for my condition. Would medical aids pay for any of this?
Most medical aids, just out of a normal savings account, don't pay for it. But I think 1 or 2 medical aids where you have the insurance plan. Now, you know this better than anybody, and I mean, you can explain this again maybe to your listeners, but in the typical insurance plan where you have built up a level of savings, they allow you to spend that savings on whatever you want to spend it on, but that's a different category. And some of those medical aids have started looking at it, but your usual run-of-the-mill typical medical aid, even though I've had high-level meetings with many of them, are still unsure how they should approach it.
Right. So we're talking about the actual cannabis. So I mean, as a consult, as a doctor, I presume a medical fund would pay for as a consult.
Yes.
What we're talking about so for our listeners, give us an idea in terms of costing. So on a traditional for treatment of, say, a common disorder, what would an individual be in for if he's going to be paying for this medicinal cannabis?
Okay, so if let's look at the most common prescription, insomnia. So you would typically then get a 1-to-1 oil. It's CBD to THC ratio 1-to-1 oil. There's 30 mils in that oil. There's basically then 600 drops in that bottle. You'll pay 1,200 Rand for that bottle, but using it for sleep. So you're only using it at night. A typical dosage would be 4 drops at night. So you could stretch that bottle to last 2 months. Some patients use it for 3, some even as much as 4. You could also buy pastils. A pastil is like a gummy type.
Yes.
It looks like a gummy. And you can cut that pastil into many small parts. You can still do titration with it. And it's going to work out cheaper actually using the pastils, because now your treatment falls to 250 Rand a month, even less, because I've found some of my patients need a fifth of that pastil, and they're buying 30 pastils for 300 Rand. So that is how patients start stretching.
Right. So, I mean, if we compare to traditional medications, I mean, it doesn't sound excessive to me. In fact, a lot of what you're saying sounds actually cheaper than some of the traditional pharmaceuticals that you would be having to pay.
Yes, but then there are the patients who have severe pain who are going to spend more. They're going to use a whole bottle of 1-to-1 oil in a month because they've got severe cancer pain. There's not much that you can do about that, and their costs are going to be significantly higher.
Right. Okay. And currently, that's, as we've said, is pretty much paid by the individual
at
the moment.
Yes.
And hopefully we'll see that changing soon or over a period
of
time.
I'm hoping so.
So we've said there's oils, capsules, vaporizers. Are there any other types of forms that one would get medicinal cannabis in at the moment?
So it's oils, pastils, gummies, and there are vaporizers. It looks like a vape, but it's a very specific medicinal application. So low temperature. So you don't want to combust material like a person who's smoking a joint.
Yes.
So these vapes are designed that it only humidifies. That's the best word that I can use.
Yes.
The oil. So, but it looks like you're taking a drag from a vape, but it's very convenient because it works fast. And my patients with pain or breakthrough pain in the day, they take a drag from this through the course of the day to help them. And then we have something called a medicinal herbal vaporizer, where you can take the flower and put it into a little chamber in a device that is temperature control, that humidifies that actual plant. And then the patient can take a single inhalation every 3 hours to help their pain, help their anxiety, or for their sleep. But the temperature is everything here, because the cigarette coal burns at 900 degrees Celsius. But any medicinal cannabis vaporizer to be called that, to even qualify for that, needs to burn below 240 degrees Celsius. So it's a major difference in temperature that we're talking about here to get to the point of where you're creating a vapor.
Anton, do you see cannabis or medicinal cannabis becoming part of mainstream medical practice in the next decade?
I really hope so. When I see how many of my patients where it's changed their lives, especially for the top conditions that I've listed, I would hope that doctors would become more open to it, that this is something that you can integrate into a patient's treatment protocol. But I think there's a lot of education that still needs to happen for us to get there.
And if you could correct one common myth or misconception about medicinal cannabis in medicine today, in 2025, what would that be?
Cannabis is not the gateway. Medicinal cannabis is not a gateway. If you buy your cannabis behind the fast food store on a Saturday night, then maybe you're messing around with gateway stuff. But medicinal cannabis is not a gateway. It's an exit. You can help patients to get off some really nasty, strong medication.
And I think that's a very important takeaway point on our podcast. So thanks so much, Anton. For our listeners who are curious about whether cannabis might help them, I suppose the advice is to go to the website, as we mentioned. Maybe you'd just like to repeat it once more for them.
That's www.introcan, and there's 2 N's at the end there, .com.
Dr. Anton Janse van Rensburg, a specialist in medicinal cannabis. Thank you so much for the information today. I'm sure we'll want to bring you back onto our podcast, and I'm sure there'll be many more questions coming out of this. It was certainly educational for me, and the real interesting work you're doing in this field. And please keep us updated. Thanks so much for your time. It's been an absolute pleasure.
Thank you for having me.
Great. Thanks, everyone, and cheers.
Well, there you have it. Our posters for this 2-part series, we poked fun at the highs and lows of medicinal cannabis. We had a joke about that. But as we've heard, with responsible prescribing and dispensing, there should be none of those highs associated with recreational cannabis use, and no real low points either. It's it's just natural healing. So
no, exactly. And as we've heard, the dosing is actually microdosing.
Sure.
Right? Yep. So it's really to treat condition specific or conditions and their symptoms, and it's not about, you're not going to get high in terms of the highs that we know happens in recreational cannabis. This is not what it's about. It's about treating the condition and getting the individuals off other perhaps addictive drugs, and it's actually hopefully would be beneficial to those patients in the longer term.
Sure. So Alan, having watched this 2-part series, there's a natural question we've got to ask. Why don't medical aids cover medicinal cannabis, number one, and number two, these other alternative medicines? I mean, if you can just give us a
very good question, Warren. Our medical system or our health system is embedded in a hospice-centric and a curative model. If you are feeling ill, you would go to your pharmacy and they would give you drugs to cure your headache. If you're feeling a little bit worse, then you would go to your doctor, and your doctor would refer you to a physician. And that's the nature of our system. The system will evolve over time. If you just think back a couple of years back when penicillin was discovered and where we are today with biological drugs, and Dr. Everon is more qualified to talk about this, but I am convinced that this health system in our country, which lacks preventative and alternative systems, will evolve. And, the world is more health conscious and wants to avoid toxic drugs in their bodies. And alternative medicine like cannabis, medicinal cannabis, is most probably a way to go. I know certainly that I travel the world, and if you look at the eastern environment of the world, they're very much into alternative medicines. The West is now catching on to this, and it will come our way. And I think a doc could most probably add more value in the discussion on the evolution of medicine and pharmacology.
And exactly right. And Warren, the wheels of healthcare funding move slowly, right?
Sure.
So we knew a while back biologicals would never be covered, and we see they being covered, right? Medicinal cannabis is a fairly new area. I believe over a period of time that it will come into the funding model, because ultimately it actually will assist medical funds, because you're going to find patients, as we heard from Dr. Anton Janse van Rensburg, he was saying that the purpose of medicinal cannabis, the microdosing, is to get individuals off the highly addictive, expensive compounds, right? So over a period of time, it's definitely beneficial for the funders, but it takes time and evidence-based medicine and time for it to move slowly. We do know, as he mentioned, that these are SAPRA registered. So that's the first step from a regulatory perspective. So that will filter into the funding mechanisms, and hopefully over a period of time we'll see that the medical aids will do it, because ultimately it will benefit. We know the costs range, right? So as was mentioned, to reasonable amounts to quite expensive amounts. So that will obviously have to be managed and controlled.
And I guess at the end of the day, medical aids are a cost conscious vehicle. they've got to be aware of what they're spending, because it affects the contribution. So
true.
we understand that. But I'm just taking comfort from both sides of the story here, that the wheel is turning slowly. But I think we'll get to that point where these sort of alternative therapies will be funded in some way.
Well, definitely. Ultimately, it will benefit the funds and it will benefit the patients. So ultimately, over a period of time, we hopefully will see that come into play.
Yeah.
The research into medicinal cannabis is a long way to go.
Yeah, sure.
And if you really look at it becoming topical, was post-COVID, really.
Yeah.
And as Doc everyone says, is that yes, the wheels are turning slowly. There are some elements approved by the Controls Council, and I'm sure, Warren, that we will eventually get there.
Yeah. So look, I think it's a watch the space kind of thing, and we will look at it, and we'll ask the questions that need to be asked when they arise.
Yeah, we definitely will ask the questions, and I suppose that's what listeners can expect from us, as this podcast series, and we'll get people onto this podcast to ask those questions.
And you'll see the address above us now, the Ask Dr. Avron address. Please send us your topics that you want us to ask the questions on. We know that we're going to ask the questions.
Exactly.
So we're not scared to ask the questions. So send the information.
Exactly.
We'll investigate.
I would ask the listeners either if they've got any comments on medicinal cannabis they want to share with us, or the funding, or any other topics that they'd like us to investigate or cover in this show, and we will definitely do it. We're not scared to.
No, we're not scared to.
Yeah. We will go out there, and that's the whole point of this podcast, to get the real information about medical treatment in fact in South Africa.
This is your podcast. This is where you get information, and information that could assist in managing your health. Thank you.
Great. Excellent. Until the next episode.
Great.
Bye for now.
Cheers,
Thank
everybody.
you.
Bye.
Cheers.
Don't stress, the gap is covered.
Well, there we go. Thank you to the TRA team and to you for watching the Inside Track. Until next time, bye for now.